palsy that time. It was somewhere in the 19th century that he mentioned it in his book, but it was later named by Dr. Jean-Marie Martin Charcot in the 20th century as actually Parkinson's disease. So there are basically two kinds of disorders. There are extrapyramidal disorders and there are pyramidal disorders, and Parkinson's disease, as we all know, is basically an extrapyramidal disorder. So these extrapyramidal disorders can be classified as akinetic rigid syndromes, which is Parkinson's and the variants of Parkinson's, and they can be classified as hyperkinetic movement disorders. So hyperkinetic movement disorders are tremors, chorea, a lot of other hyperkinetic movements like Tourette's syndrome, tics, motor stereotypies. So we'll basically focus on these akinetic rigid syndromes. Now, akinetic rigid syndromes are broadly called as Parkinsonism. They are basically a group of disorders that are due to the abnormalities of basal ganglia. And Parkinsonism comprises of four basic things, that is tremors, rigidity, postural instability, and bradykinesia or akinesia. So any patient who has two of these features can be called as Parkinsonism. This is not Parkinson's disease. Parkinsonism has got lot of causes. The commonest is idiopathic, which is called as Parkinson's disease. There are a lot of other secondary causes of Parkinsonism like viruses, toxins, drugs, tumors. As we go further, we'll discuss that. So the point to understand here is Parkinsonism is just a clinical syndrome of tremors, rigidity, akinesia, bradykinesia, or and postural instability. And Parkinson's disease is Parkinsonism which does not have a cause. That is, idiopathic Parkinsonism is called as Parkinson's disease, and Parkinson's disease is the commonest cause of Parkinsonism. So make it very clear here that Parkinsonism is different, Parkinson's disease is different. Parkinsonism has got a lot of causes. One of them and the most common is Parkinson's disease, but there are lot of other identifiable or reversible causes. So whenever you come to deal with any patient of Parkinsonism, not Parkinson's disease, Parkinsonism, your main approach to diagnosis of Parkinsonism should be to try and find out what are the reversible or what are the treatable causes. I'll tell you what are the reversible causes. There's a lot of causes for Parkinsonism per se. So what are the cardinal features of Parkinsonism? Tremors at rest, rigidity, bradykinesia or akinesia, loss of postural reflexes or postural disturbances, and two other which are flexed posture and freezing. These are number 5 and number 6 are not mandatory. The first four, out of the first four, at least two should be present. Bradykinesia is a must, and out of tremors, rigidity, and postural instability, one should be present. So bradykinesia plus either tremor, either rigidity, or either postural instability is classified as Parkinsonism. And of that, if you have flex posture and freezing of gait, then it adds to the diagnostic certainty of Parkinsonism. Now, if you look at Parkinsonism, as I said, there are a lot of causes of Parkinsonism. The commonest cause of Parkinsonism is idiopathic, which is called as idiopathic Parkinson's disease, which we all know. And one of the other common cause is drug-induced Parkinsonism. There are a lot of drugs cause Parkinsonism. I'll discuss that in detail because as clinicians, we should be aware which of our drugs can actually cause Parkinsonism. Then third is vascular Parkinsonism. Vascular Parkinsonism is something that we see in patients who've had recurrent strokes. So that is vascular Parkinsonism. And then there are three atypical Parkinsonian syndromes, which are called as Lewy body dementia, progressive supranuclear palsy, and multisystem atrophy. We won't go too much into details of these three syndromes, but the most important is idiopathic Parkinson's, drug-induced Parkinsonism, and vascular Parkinsonism. So that is the classification of Parkinsonism. Now we try to stick to idiopathic Parkinson's disease. So its prevalence is about 1 to 2% in population who are more than 60 to 65 years of age, which is very, very common then. And 0.3% of the general population are known to have idiopathic Parkinson's disease. Why it is so important is because it is the second most common neurodegenerative disorder after Alzheimer's disease. males epidemiologically are more affected than females. It's about 3:2 in most of the studies. So what is the definition of Parkinson's disease? Now, I always in my talks, if you have attended my talks, I always stress a lot on definition of any disorder. So why definitions are very important is because they help you understand the disease a lot better. So what is the definition of Parkinson's disease? It is a clinical and a neuropathological entity. Now, why these two words are very important, clinical and neuropathological, is because first and foremost, Parkinson's disease is a purely clinical diagnosis. And why I say neuropathological is because the only way to definitely define Parkinson's is by pathology. That you do a brain biopsy, stain it with various stains, and then try to show that there are loss of dopaminergic neurons in particular areas of the brain. There is no diagnostic test like MRIs, CT scans, blood tests to diagnose Parkinson's. Make this point very clear. There are no diagnostic tests for Parkinson's. It is a clinical and a neuropathological entity which is characterized by bradykinesia, rigidity, tremors, which is asymmetric in onset. One. Second is they should be responsive to dopaminergic treatment. Responsive to dopaminergic treatment means whenever you use something like Syndopa or other dopaminergic drugs, they should respond to that in adequate doses, of course. There should be no historical or no examination clues to indicate secondary Parkinsonism, in the sense that there should be no history of any drug intake which is known to cause Parkinsonism. And of course, last is in case you manage to do a biopsy, then pathology should show abnormalities in the dopaminergic pathways of the brain. So that is the definition of Parkinson's disease. So I hope this is very clear. The definition of Parkinson's disease: clinical neuropathological entity characterized by bradykinesia, rigidity, tremors, which is asymmetric in onset. It should be responsive to dopaminergic therapy, and there should not be any alternative cause for Parkinsonism. So what are the risk factors? These are not foolproof. They've found these are not actually risk factors. These are only associations. They're not exactly risk factors. They found that there is increased risk with pesticide exposure, those who have had prior head injury. So if you know the great boxer Muhammad Ali, he had something which was called as punch drunk syndrome. So because of recurrent boxing fights, he developed Parkinsonism. So prior head injury, rural living, use of beta blockers, they say, agricultural occupation because of pesticides, drinking of well water. Whereas those factors which reduce the risk of Parkinson's are tobacco smoking, coffee drinking, NSAIDs, calcium channel blockers, or alcohol. But I don't advocate any of this. Neither tobacco nor coffee nor NSAIDs nor alcohol. So, but these are protective, they say. Then there are a lot of genetic factors. One of the common genetic factors is LRRK2 mutation. Now, this LRRK2 mutation has been found to be very commonly associated with young onset Parkinson's. So that's the only thing to remember in this, that is LRRK2 mutation. So now then we come to the pathology. I'm not going too much into details of pathology of Parkinson's. What you need to understand is what are the structures that are involved in Parkinsonism or Parkinson's disease. They are basically the basal ganglia, and the basal ganglia comprises of the caudate nucleus, the thalamus, the globus pallidus, the hypothalamus, the subthalamic nucleus, and there is a pigmented structure here which is called as the substantia nigra. So these are very rich in dopamine and acetylcholine. And when these structures start degenerating, that's when the dopamine levels reduce, and that is what causes Parkinsonism or Parkinson's disease. Now, clinical features I've already discussed. Now we come to individual clinical features. Now, the first and the commonest clinical feature, which is a must to actually diagnose Parkinson's disease, is bradykinesia. Now, what do you mean by bradykinesia? We all have heard that the patient should be bradykinetic. What do you actually mean by bradykinesia? Bradykinesia not only means reduction in the speed, but it also means that there should be a reduction in the amplitude of movements of the body. So they should be slow, one. And second is the amplitude, that is the range of motion should also be less to actually cause it bradykinesia. So reduction in the amplitude as well as the speed of alternating movements. Now how do you ask the patient to demonstrate bradykinesia? I'll be showing you a few videos after a couple of slides which will help you to understand what is bradykinesia. uh, First way to demonstrate bradykinesia is you have to ask the patient to alternately finger tap. That is the index finger and the thumb finger. You ask them to tap like this, and so the amplitude and the speed of movements will be very low. Or you can ask them to do rapid alternating hand movements. That is, flutter their hands and see that movement will be slow and the amplitude will also be less. The other displays of bradykinesia can be hypomimia. So if you've seen a Parkinsonian patient, they usually have a poker face. There will be no expression on their face. There will be no smiling. There will be no grimacing. Nothing would be there. It will be just a blank face. So hypomimia is one of the manifestations of bradykinesia. That is mask facies, we call it. Second is hypophonia. That is the volume of speech will be very less. Next is micrographia. If you ask them to write, once they start writing, the letters would be fine. But as you progress further, the letters will start becoming smaller, smaller, smaller. That is called as micrographia. And last is symptomatically, the patient would say that they take more than usual time to actually eat their food. So that is difficult. That is because of slowness in swallowing or difficulty in swallowing. So this is about bradykinesia. I'll show you a few videos so you'll understand it better. Now, coming to the next common manifestation of Parkinson's disease, which is called as rest tremors. So tremors, we all know, are rhythmic, oscillatory, involuntary movements. But the rest tremors are those tremors which come when the body part is relaxed. Normally, how do we test tremors? We ask the patient to outstretch the arm and then we test for tremors. But in Parkinson's patients, you don't have to outstretch the arm. When you outstretch the arm, you will not see any tremors. You have to just observe the patient when the patient is sitting, and there will be tremors when the patient's arm is rested on the table or it is rested on their thighs. So they'll have tremors then, but when you ask the patient to outstretch their arms, the tremors will disappear. So when any tremor is seen when you're outstretching the arm, it is basically action tremors. They are not rest tremors. Rest tremors come when the patient keeps their hand on the table or it is in rest. Now, another common feature of rest tremors in Parkinson's is re-emergent tremors. So re-emergent tremors means you ask the patient to outstretch their arm and tell them to keep the arm outstretched for about 30 seconds. Beyond 30 seconds, now they will start developing the tremors. First 30 seconds, there'll be no tremors. But when you tell them to keep the arm outstretched, they'll start developing the tremors again, which are called as re-emergent tremors. So if you have any patient with rest tremor and you have a doubt whether it is Parkinson's or not, you ask them to outstretch their arm, tell them to keep their arms outstretched, and then look at it. And they'll again, after 30 to 45 seconds, they'll start developing the tremors. That is called as re-emergent tremors. Another characteristic feature of Parkinsonian tremors are pill rolling tremors. It's as if they are rolling a pill or a cotton wool. How you roll a cotton wool, it's like that. That's called as pill rolling tremors. I'll show that to you in the video further. Tongue, jaw, and lower limb tremors are also very common in Parkinson's, particularly in advanced Parkinson's. So tongue, jaw, and lower limb tremors are also common. If you see a patient with head tremors, 9 out of 10 of those patients will not have Parkinson's. So head tremors, you should remember, are atypical basically of Parkinson's disease. You don't see head tremors in Parkinson's disease patients. So rest tremors, re-emergent tremors, pill rolling tremors, tongue, jaw, and lower limb tremors. These are basically the characteristic tremors of Parkinson's disease. Then you come to the next manifestation, which is rigidity. Rigidity basically refers to an increased muscle tone that you see while passive movement of the limb. So you move the upper limb or the lower limb passively, and you will see that the limb is rigid. You will find a lot of resistance when you're moving the limb, and the resistance will be felt throughout the range of movement. And when these patients have associated tremors, you will feel as if it's like a cog wheel. Cog wheel is like a bullock cart wheel. When you see a bullock cart wheel, it when it moves on the ground, it's a little bit tremulous. If you've seen a bullock cart wheel, I don't know if you've seen a bullock cart wheel, but it's very tremulous. So there will be a lot of vibration when you're moving the arm to test resistance or to test rigidity. And there's something that is called as Froment's maneuver. So if you are testing a patient who has very early Parkinson's and you look for rigidity and you don't actually find that the limb is rigid, then what you do is you ask the patient to do some activity with the other limb. The other limb, you ask the patient to do some activity like tapping their fingers, or you distract the patient and then test the rigidity in the contralateral limb, and then you will find rigidity in the contralateral limb. So when you're distracting the patient by asking him to do something with the other hand and test the rigidity in the other limb, you might find rigidity in the other limb if it is a very subtle rigidity. So that is called as Froment's maneuver. And then you come to postural and gait impairment in Parkinson's patients. Now, this is again a very important manifestation of Parkinson's disease. First of all is Parkinsonian gait. So they become slow. They have these short shuffling steps, which gives the observer the impression that the patient is chasing their own center of gravity. There will be a lot of truncal flexion when they walk. So they will be stooped forward or bent forward. And while they are walking, there will be a decreased arm swing. So when they walk, normally we swing our arms when we walk. But when these Parkinsonian patients walk, it's as if one of their hands is not moving at all. So decreased arm swing, slow, short stepping, narrow based gait. Walking and turning is very difficult in Parkinsonian patients. So particularly when you distract these patients, if you're talking to these patients, it becomes even more difficult for them to turn. And there's a test which is called as pull test, which when you stand behind the patient and ask them to pull, you pull the patient actually behind, they are not able to hold their balance. Normally if I pull you, you will be able to hold your balance, you won't come behind. But if you ask a Parkinsonian patient to hold themselves and you pull them from behind, they'll not be able to hold themselves, which is called as the pull test or postural instability. So these are a few features, clinical features of Parkinson's. I'll just show you a few videos now. Uh, I'll just try to show you a few videos. Is this video visible?
No, sir.
I'll just try again.
Not yet.
Is the video visible? Any video visible now?
No. You may double click करोगे तो it will start. It has not started.
Acha, okay.
Yeah, Dr. Dinesh, I just want to make one announcement. Anybody who wants to ask questions, you can please ask on the chat. So the questions will be taken at last.
Now anything is visible? No.
No.
Yeah. Is this visible? Is this video visible?
Yeah, but
Hello.
yeah, it's visible, but it's not playing.
I'll play 1 second. Yeah, now is it playing?
Yeah.
Yeah, now is it playing?
No, sir. Yes, it has started now.
Yeah. So you can see this patient. I'll play again. You can see the hand. Now these are basically the pill rolling tremors that you see in the right hand. So you are distracting the patient by asking him to do some movement with the left hand, and there are some tremors in the right hand that you can see. These are basically rest tremors and pill rolling tremors that you can see in this video. Are you able to appreciate the pill rolling tremors?
The video is lagging. It is very slow.
Yeah, is it visible?
It's visible, but it's very slow. The video is very slow.
Uh-huh. So what was seen in the video was basically pill rolling tremors of the right hand. I'll go back to the presentation. I think playing video is a little
Yes.
difficult.
Yeah.
I'll go back to the presentation. So these are mainly the clinical features of Parkinson's. Now I'll just maximize the window. Yeah. So these are basically the clinical features you can see in this diagram. Now the presentation is visible, madam. Yeah.
Yes.
Yes.
Now you can see in this picture all the cardinal features of Parkinson. So you can see an old man who has got a stooped posture. Okay. If you see his arm swing, the left arm is not swinging as much. The right arm is still in motion. He has a mask-like facies, stooped posture, tremors of the left upper limb, and short shuffling gait. So this is basically, in short, how a Parkinsonian patient looks. Now, this is the pull test that I was saying. So ideally you stand behind the patient and you pull the patient, telling him that, okay, I'll be pulling you and you have to hold your balance. And when you actually pull them, they are not able to hold their balance and they actually come behind. Normal people won't come behind more than 1 to 2 steps, but Parkinsonian patients will come behind more than 2 to 3 steps. So that is basically what is called as postural instability. Now, this is a diagrammatic representation of the gait of Parkinsonian patients. So if you see these patients, they have tremors of both the hands, they are stooped, and when they walk with a very short stepping gait. So normally when we walk, the distance between our 2 feet is much longer than what you are seeing in the diagram 1. And second is they are barely able to lift the foot off the ground. Normally when we walk, we lift the foot and put it forward. Here they are actually dragging their feet and they are walking. So that's the gait. Then there is something which is called as freezing in these patients. So freezing means when you tell them to walk, suddenly they will just stop at a particular point. They will be frozen on the ground as if something is stuck to their feet and they will not be able to move beyond that. And then when you ask them to lift their leg and put it forward, they'll be able to walk. So that is basically called as freezing or motor blocks. Then this is a portion of very advanced Parkinson's, which is called as camptocormia or severe flexion of the trunk. So this is basically very advanced Parkinson. This is camptocormia. Then there are a lot of bone deformities. These are not very common, so we skip this. Now, there are a lot of non-motor symptoms in Parkinson's disease, which we should be aware, because these non-motor symptoms we need to address equally. They are equally important to be treated. Now, there are a lot of neuropsychiatric symptoms that you see in patients with Parkinson's. The commonest that I have seen is depression. So depression is one of the commonest symptoms. Then you have hallucinations, illusions, delusions. Now, hallucinations, illusions, delusions, if you see very early in Parkinson's disease, there can be only two possibilities. One, they are either drug-induced hallucinations or delusions, or it is not a typical Parkinson's, it is some atypical Parkinson's. So these are a few neuropsychiatric symptoms. A lot of others, dementia usually occurs very late in Parkinson's disease. Some people have obsessive compulsive behavior, confusion, delirium. Again, delirium could be drug induced, and panic attacks. Now, why I have mentioned this slide, this neuropsychiatric symptom, is because most of the anti-Parkinsonian medications cause these symptoms. So whenever you have any Parkinson's patient who was not having these symptoms and you have started your medication, then you start developing these symptoms, that means it might be drug induced. So you should be aware that all anti-Parkinsonian drugs have side effects in terms of hallucinations, illusions, delusions, confusion, delirium. So all anti-Parkinsonian medications cause this. I'll come to that when we discuss the management of Parkinson's. Then there are bladder disturbances. I'm sure you must have seen a lot of patients who have urgency, nocturia, increased frequency of micturition. Then a lot of patients have orthostatic hypotension. Now, orthostatic hypotension, why it is very, very important. Now, this is a very important point. If you see many Parkinson's patients, or if a lot of patients come to you who tell you कि जब भी हम लोग खड़े होते हैं तो आँख के सामने अंधेरा आता है, those kind of symptoms, and when you examine them, you actually find them that they are slow, they are having some tremors. Okay, so then you should always suspect that it is Parkinson's, and the dizziness that they are having is not actually vertigo, but it is more of orthostatic hypotension. So you should always check blood pressure in lying position and in standing position. Vice versa, if you have a Parkinson's patient who comes to you, Parkinson's patient is showing a neurologist and he suddenly comes to you and he tells you, okay, I am having this lightheadedness, or I'm getting these symptoms of aankh ke samne andhera, and when I get up, I feel that I'm very dizzy. Always check their blood pressure in lying position and in standing position, and ask them what medication they are taking. Now, why medications is important is because Syndopa itself causes orthostatic hypotension. So if you have significant orthostatic hypotension, you need to reduce Syndopa dose. And the other reason could be Parkinson's itself causes orthostatic hypotension. There's no doubt about it. But the other reason could be, if you see what I mentioned here, bladder disturbances, and they might have gone to a urologist or a general surgeon for bladder disturbances, and they prescribe them these Urimax. Urimax is very notorious, or all these alpha blockers are very notorious to cause orthostatic hypotension. So you should be aware that Parkinson's disease itself can cause orthostatic hypotension, but at the same time, the medications that we use for Parkinson's, they can also cause orthostatic hypotension. So you should be aware of this non-motor symptom of Parkinson's. Very, very important. Why it is important? Because when you start having severe orthostatic hypotension, patients tend to start falling. So that's the problem with orthostatic hypotension. You should be very, very aware of this problem in Parkinson's. So what I want to stress here is orthostatic hypotension, bladder disturbances, depression, hallucinations, illusions, delusions, and delirium. These are common non-motor symptoms of Parkinson's, and at the same time, there's a very high chance that your medication which you're using to treat Parkinson's can cause these non-motor symptoms. So you should be aware of this. That's the learning point here. Then there is something which is called as sleep disorders, or sleep related symptoms of Parkinson's. Now, one of the commonest sleep related symptoms of Parkinson's is called as restless leg syndrome, or periodic limb movements in sleep. Now, what do these patients complain? Now, these patients will tell you that whenever we go to bed, we have severe cramp in our legs. Whenever we go to bed, during the daytime we are all fine, but whenever we go to bed, we have severe cramps in our legs. We start massaging our feet, or कोई आके पैर पे खड़ा रहना पड़ता है. Those kind of things करने से they feel better. Now, during the daytime we are all fine. There is no problem during the daytime. Now, this symptom is classically called as restless leg syndrome. This is one of the non-motor symptoms of Parkinson's. The treatment for restless leg syndrome in Parkinson's is you can use gabapentin or pregabalin, but more than that, you can use any of these dopaminergic drugs like Syndopa or pramipexole or ropinirole, or Ropark, which is called. So that is very important. Restless leg syndrome is very important. So this is a sleep related symptom of Parkinson's. Insomnia, they have OSA. So these are other non-motor symptoms of Parkinson's. Now, I'll come to how do you diagnose Parkinson's. The most important thing is there are no tests that are available to diagnose Parkinson's. The only thing that you need is an expert clinician to diagnose Parkinson's. There are no tests. MRI is just to exclude other causes of Parkinson's, and there is a scan which is called as the dopaminergic scan, or the DAT scan. The DAT scan you can use in certain unclear cases. I'll discuss the DAT scan. I'll tell you what the DAT scan is in detail. But again, to stress that there are no tests to diagnose Parkinson's. You just need an expert clinician to diagnose Parkinson's. MRI is just used to rule out the mimics of Parkinson's disease. So how do you diagnose Parkinson's? First is you establish that the patient is Parkinsonian. How do you establish the patient is Parkinsonian? Is by this mnemonic, that is TRAP, that I discussed earlier. tremors, rigidity, akinesia, and postural instability. And other than that, there should be a clear response to dopaminergic therapy. That is, all these symptoms should resolve or should show some improvement after giving them syndopa, levodopa, or any of the dopaminergic drugs. So first of all is you have to establish Parkinsonism. That's the first step to diagnose Parkinson's disease. You establish that the patient is Parkinsonian. Second is you have to look at the supportive criteria. So once you have diagnosed that patient is Parkinsonian, the second step is you should give them a dopaminergic drug, either ropinirole, pramipexole, or syndopa, and there should be a clear and a dramatic response to dopaminergic therapy. Second is these patients can develop levodopa induced dyskinesia. So if the patient says ki after starting your medications I have developed some abnormal movements in the hands and feet after starting levodopa, that means it supports that your diagnosis is correct of Parkinson's disease. What you have to do is just reduce the dose of levodopa. So these are two supportive criteria which are very, very important. However, you should always look at the red flags in any Parkinson's disease. Now, what are the red flags and what do you mean by red flags? Whenever you get any of the symptoms in red flags of Parkinson's disease, think other than Parkinson's disease. Probably your diagnosis is wrong. It may be some atypical Parkinson's or it may be some secondary Parkinson's. So what are the red flags? First is rapid deterioration of gait. The relatives will start telling you that the patient is rapidly deteriorated in terms of walking. He's just not able to walk in the last 3 to 4 months. Previously, he was fine. You see the patient is bradykinetic, hypomimic, but Parkinson's disease does not produce rapid deterioration of gait. Usually typical Parkinson's patients become bedbound only after 10 to 15 years of the disease onset. So if the patient comes to you with 3 months history कि patient 3 महीना पहले चल रहा था और अभी चल नहीं सकता है, don't diagnose them as idiopathic Parkinson's, investigate them thoroughly. So what investigation, that I'll tell you in the next slide. Then second is early bulbar dysfunction or respiratory dysfunction. Patient tells you कि पिछले 2 महीने से patient is not able to swallow. Patient came to you in the OPD, you diagnose him as Parkinson's. They come back after 15 days and tell you कि patient is not able to swallow, or the patient is having respiratory difficulty, or patient is having severe autonomic symptoms like sweating, urgency, urge incontinence, bladder symptoms very early in the disease course. That means it's not a typical Parkinson's. It is some atypical Parkinson that you're dealing with. So early deterioration of gait, early bulbar dysfunction, respiratory dysfunction, severe autonomic failure early in the course, early falls. Parkinson's patients don't fall very early into the disease. They start falling only after 7 to 8 years of the disease. So any patient who comes to you where you have diagnosed Parkinson's and they say कि patient अभी 2 महीने से गिरने शुरू हो गया है, you just diagnosed patient as Parkinson's and patient comes to you after 2 months saying कि patient started falling. So early falls, you should be thinking away from idiopathic Parkinson's. So these are basically a few things which are red flags. So whenever you have any of these symptoms, you should start thinking away from Parkinson's. Then what are the exclusion criteria for Parkinson's? So if you have any of these symptoms, it is not Parkinson's disease, it is something else. So if you have any cerebellar signs, that is upper limb ataxia or lower limb ataxia, don't diagnose them as Parkinson's. It might be some cerebellar disorder. If you have memory symptoms early in the disease course, or if you have behavior symptoms early in the disease course, think away from Parkinson's. If the Parkinson's is restricted only to the lower limbs for more than 3 years, upper limb there are no slowness. If it is restricted only to the upper limb, think away from Parkinson's. If the patient is on any medications which cause Parkinsonism, don't diagnose them as idiopathic Parkinson's. If you have started the patient on levodopa and you have given enough dose of levodopa for about 3 to 4 years, think away from Parkinson's. So these are a few exclusion criteria. You should keep away from diagnosing Parkinson's with these exclusion criteria. Now, what are the secondary causes of Parkinson's? So idiopathic, I told you, idiopathic, there is no cause, that's the commonest, but that is 75% of the cases are idiopathic. But you should always look at certain reversible causes or symptomatic causes. One of the commonest symptomatic cause is drug-induced Parkinson's. So I'll just tell you a few common drugs which cause Parkinson's. Antipsychotics we all know cause Parkinson's. So phenothiazine group of drugs, chlorpromazine, prochlorperazine, fluphenazine, promethazine, haloperidol, that is your Serenase, which is commonly used, pimozide, sulpiride, that is your amisulpiride, that is used by the psychiatrists. Now, these typical antipsychotics or older antipsychotics, that is your commonest is haloperidol. They are the commonest cause of Parkinson's. You should always ask the patient history of drug intake. So if they have a history of taking haloperidol or amisulpiride and they have developed tremors after that, you should always tell them to avoid these drugs and then reassess these patients. They might just improve after stopping these medications. Then atypical antipsychotics or the newer antipsychotics. So risperidone is one of the commonest newer antipsychotic which causes Parkinson's. Of course, it is less as compared to the typical antipsychotics. Olanzapine is again another drug which causes Parkinsonism. Then there is tetrabenazine. Tetrabenazine is used for tics, that is Revocon. So if the patient is on Revocon for tics and they become slow, it's probably because of Revocon or tetrabenazine. Then your antiemetics, which is metoclopramide, which is Perinom. So Perinom is very, very commonly known to cause Parkinson's. Levosulpiride. Now, levosulpiride, I want to stress on this drug. Now, a lot of physicians and a lot of us use levosulpiride. Now, those people who have worked with me, who are listening to me, they know that I don't like this drug at all. Now, this levosulpiride is what you call as Pantin-L or Razo-L or Pan-L or that L preparation. It is very, very notorious to cause Parkinson's. Particularly, they present with these oral dyskinesia. So you might see a lot of lip smacking, lip chewing kind of movements after taking levosulpiride. So if a patient comes to you with these abnormal perioral movements and you have started the patient on levosulpiride, please stop levosulpiride. It is almost completely reversible after stopping levosulpiride. So levosulpiride is a very, very notorious drug to cause Parkinsonism. None of the neurologists will advocate levosulpiride. Even if you're using levosulpiride as a prokinetic, please use it in very, very small doses and try to take them off as early as possible. Then another commonly used drug which we abuse actually is flunarizine. Flunarizine is your Cybelium that we use for Parkinson's disease. Now, make one point very clear in your clinical practice. Do not use flunarizine for old patients with migraine, particularly patients who are above 50. Don't use Cybelium in these patients because it's very, very notorious to cause Parkinson's. Why I'm saying this so strongly is because first is migraine medications have to be continued for 6 to 9 months. Second is flunarizine in old patients with migraine definitely produces Parkinson's. I have a lot of patients who have been on Cybelium for years together and they come to me with Parkinson's disease. If you tell them to stop Cybelium, they they get very agitated, saying that हम इतना साल से ले रहे और हमको नहीं, वो इतना साल से लेने के वजह से ही हुआ है. So that's what you need to understand, that Cybelium can cause Parkinson's. Cinarizine is your Stugeron. So you have a lot of patients who keep coming to you with vertigo, recurrent vertigo. We keep giving them Stugeron. And then what happens one fine day is they don't come back to you. They will just keep taking Stugeron because they get better after taking Stugeron and they keep continuing to take Stugeron. So many patients of Stugeron-induced Parkinson's. You stop the Stugeron, they might improve partially. But this is what, as clinicians, we should be aware that flunarizine and cinarizine are very notorious to cause Parkinson's. Now, there are certain other drugs, antidepressants, which you should know they can cause Parkinson's. One of the commonest drug is valproic acid. So I have a few patients who are bipolar disorders who have been on divalproate for a long time. Valproic acid can cause Parkinson's. Long-standing use of domperidone can cause Parkinson's. SSRIs, your Nexito, Fludac, all these drugs, sertraline can cause Parkinson's, but they are less. The safest antipsychotic that if you really want to use in Parkinson's patient is clozapine or quetiapine. They can cause, but they usually cause at very higher doses. So if you have a case of Parkinson's disease who you need to use some antipsychotic, you can use clozapine and quetiapine. They are less prone to causing Parkinsonism. This slide is very, very important. Try to remember as many drugs out of these as possible because it is very common in clinical practice. I would stress upon haloperidol, risperidone, olanzapine, tetrabenazine, which is Revocon. A lot of neurologists use tetrabenazine. Levosulpiride, extremely notorious. Perinom, extremely notorious. Flunarizine, cinarizine, extremely notorious. Valproate, extremely notorious. And escitalopram, Nexito, is extremely notorious to cause Parkinson's. So you should have these drugs in your mind when you're dealing with any Parkinsonian patient. So these are basically drugs that cause Parkinson's. Other things that can cause Parkinson's is hydrocephalus. So there is something which is called as normal pressure hydrocephalus. So in any Parkinson's patient, I always do a CT scan, plain CT scan. Although I'm very sure that it is idiopathic, I always do a CT scan just to rule out a hydrocephalus. One of the other common causes of Parkinson's is subdural hematoma, that is structural lesions of the brain, or frontal lobe tumors. Frontal lobe tumors are known to cause Parkinson's in the sense that they cause lower body Parkinson's. The patient will have a lot of difficulty in walking. So any Parkinson's, or at least do a CT scan to rule out hydrocephalus, to rule out a frontal lobe tumor. Any Parkinson's patient, you should always do a liver profile and ammonia test, arterial ammonia, because hepatocerebral degeneration, which is seen in alcoholic patients who have hepatic encephalopathy, it is also seen in Wilson's patients. So any young Parkinson who comes to you, always do a serum ceruloplasmin level. Hypothyroid is a close mimic of Parkinson's. So any Parkinson patient, you should do a thyroid profile. Toxins can cause, carbon monoxide can cause Parkinsonism. Certain infections, encephalitis, post herpes encephalitis Parkinsonism is very well known. So post infectious Parkinsonism is also very common. So drugs, hydrocephalus, you should always do a CT scan. Structural lesions of the brain like frontal tumors, metabolic like liver disorders, you should always check renal liver function, ammonia, thyroid and parathyroid levels, toxins, infections. So these are a few causes. Then there are hereditary disorders which can mimic Parkinson's. I'll not go into those. And then there are Parkinson plus syndromes like dementia with Lewy body, multisystem atrophy, PSP and CBJD. I'm not going into those. What is important is, as a clinician, is what you should try to rule out this group, because these are completely reversible. You'd stop the drug, they get better. Treat the hydrocephalus, they get better. Treat the liver pathology, they get better. Treat the tumor, they get better. Remove them from the toxin, they get better. Treat the infection, they might get better. And always remember Wilson's in any young Parkinson. So if you have any patient less than 50 years of age who comes here with Parkinsonism, always do their eye checkup for KF ring and do their serum ceruloplasmin level. So this is very, very important. This is basically atypical Parkinson. I'm not going into atypical Parkinson. That's a separate topic completely. Drug-induced Parkinson's, I'll just tell you a few clinical features of drug-induced Parkinson's, the drugs that we discussed. So how do you actually tell that this is because of the medicines? Parkinsonian signs in drug-induced Parkinson's will be symmetric. So it will be in both hands and both legs. I told you idiopathic Parkinson's is asymmetric. Drug-induced Parkinson's is usually symmetric. Second, they have coarse postural tremors. Parkinsonian tremors are very fine tremors and they are rest tremors, whereas drug-induced Parkinson's are coarse tremors and they are postural tremors. So you tell them to outstretch their hand, the tremors will appear, whereas Parkinsonian patient, tell them to outstretch their hands, the tremors would disappear. Then drug-induced Parkinson's, they have a lot of orolingual dyskinesias or akathisia. That is, they'll have a lot of lip chewing, lip smacking, that kind of a behavior that is caused by antipsychotics. Symptoms will start after the drug has been introduced. So you ask the patient, ये चालू किया था, उसके बाद ही शुरू हुआ क्या? And the symptoms improve markedly after a few months of complete drug withdrawal. So drugs band karne ke baad, the symptoms will obviously improve. So these are a few clinical features of drug-induced Parkinson's. MRI, there is nothing in the MRI. This is basically for differential diagnosis. Now, any test that you really want to advise the patient for diagnosing Parkinson's is DAT scan. That is dopaminergic scan. It's done in Jaslok, and I think it is done in Nanavati. These are only two places where they do it. Now, in which cases you should try to, advise a DAT scan? First is when your diagnosis is not clear, when you feel that the tremors, are they Parkinsonian tremors or they are essential tremors? Essential tremors is a common benign condition. So in such cases, you can do a DAT scan, which will help you to differentiate between Parkinson's and essential tremors. So if you see the normal DAT scan, this is a normal DAT scan. You can see this is basically the basal ganglia structure. So the dopamine uptake is excellent here. These red areas are the dopaminergic areas, which are absolutely fine here. Now you see the second image. This is basically Parkinson's patient before treatment. So you compare this image and this image, see this image and this image, the red areas are very less. So this is basically dopaminergic deficient areas. And when you treat them, they again start getting better. So this is post treatment, so they've again started getting better. So that is diagnostic of Parkinson's. Now if you have a case of essential tremors, this is the DAT scan in essential tremors. The dopaminergic uptake will be absolutely normal because essential tremors is a benign condition. It's a genetic condition. So the dopaminergic areas will be absolutely normal. You can see the dopaminergic area, they are comma shaped, excellent dopaminergic areas. Whereas in any Parkinsonian syndrome, you can see this dopaminergic area. It is so much reduced compared to this side. So the right side is a normal or an essential tremor ka DAT scan, and this is an abnormal DAT scan. So if you are not able to differentiate between essential tremors and Parkinsonian tremors, you can do a DAT scan to differentiate between them. So that's one area where you can do a DAT scan. Second is drug-induced Parkinsonism. So drug-induced Parkinsonism mein, the DAT scan will be absolutely normal. So that is about drug-induced Parkinsonism. Third is those patients whom you are planning to take up for deep brain stimulation. You can do a DAT scan just to document how much deficient the dopaminergic areas are. So these are the only 3 indications where you can do a DAT scan. Rest of it's basically a clinical diagnosis. There is no need for any investigations. Now we'll come to the treatment of Parkinson's. Now management of Parkinson's, you should consider a lot of things before you actually decide what medication to use. First is, what are the patient's symptoms and signs? What is the age of the patient? What is the stage of the disease? How much disability it is causing to the patient, and whether it's a young patient or it's an old patient. Now treatment can be divided into pharmacological, non-pharmacological and surgical therapies. We'll mainly concentrate on pharmacological therapy. Surgical therapy is deep brain stimulation. That's an entirely different topic. I'm not going there. So when to start drug therapy? Now that's the first question. You should always start drug therapy when you feel that the effect of the disease is on the dominant hand. So if the patient is a right-handed person and is not able to do activities with the right hand, consider starting drug therapy. If the patient's symptoms are interfering with the patient's work, activities of daily living, social or leisure function, you should start drug therapy. Presence of significant bradykinesia or gait disturbance, you should consider starting drug therapy. So now what are the drugs that are available for Parkinson's disease? Now for understanding the drugs for Parkinson's disease, you need to know how dopamine is synthesized and how dopamine is broken down and what are the byproducts of dopamine. Now levodopa gets converted to dopamine when it gets into the central nervous system by an enzyme which is called as dopa decarboxylase. So that's where you give levodopa to the patient, and you give it with carbidopa, that is called as syndopa. So that is levodopa plus carbidopa. What carbidopa does is it inhibits the dopa decarboxylase. So it inhibits the degradation, peripheral degradation of dopamine. So you get higher levels of dopamine in the central nervous system when you use it with carbidopa. Then the other group of drug is dopamine agonists. So dopamine agonists are basically ropinirole, pramipexole and apomorphine. So these are 3 drugs which are dopamine agonists. Then there are certain drugs which increase the release of dopamine within the central nervous system, which is amantadine, which comes to be known as parkitidine. Then once dopamine enters the central nervous system, it gets degraded by 2 enzymes, which is monoamine oxidase and catechol O-methyl transferase. These are 2 enzymes which break down dopamine into these 2 byproducts. So then they came up with drugs which inhibit these enzymes. So monoamine oxidase inhibitors are rasagiline and seligiline, and there's another new drug which has come, which is called as zafinamide or safinite. So that's a third drug here. It's a newer medicine. And there is another group of drugs which inhibits this enzyme, that is catechol O-methyl transferase, that is entcapone and tolcapone. So by inhibiting these enzymes, you are indirectly increasing the dopamine levels and you are indirectly increasing the dopaminergic effect. So these are the drugs and their sites of action. Now, what are the group of medications that are available for Parkinson's? So one is dopamine agonist. Second is dopamine agonist. I told previously, this group of drug, they act as dopamine. So they are dopamine agonists. They go to the receptor and act as dopamine. That's called as dopamine agonist. Then you have MAO-B inhibitors, which are the monoamine oxidase inhibitors, rasagiline and seligiline. Then you have COMT inhibitors, which are entcapone and tolcapone. Then you have levodopa, which is your gold standard drug. Then you have amantadine, which increases the release of dopamine. And then you have anticholinergics, which are your pacitane group of drugs. So which are used only for tremors. So these are the pharmacological treatment options for Parkinson's disease. And this is basically the group of drugs that I discussed. So this is levodopa, dopamine agonists, MAO inhibitors, COMT inhibitors, and amantadine. Now, how do you treat any patient with early Parkinson's or those patients who have very minimal symptoms? So whenever you have patients with minimal symptoms, you either use a MAO-B inhibitor or you use amantadine. These are the two drugs to use in early Parkinson's. Now, what do these MAO inhibitors do? MAO inhibitors basically reduce the metabolism of dopamine. So they indirectly increase the levels of dopamine. The advantages of MAO-B inhibitors are they are very well tolerated. They also have some neuroprotective effects. So they delay the progression of Parkinson's. And there are three MAO-B inhibitors that are available: selegiline, rasagiline, and safinamide. So you should use this for minimum signs and symptoms, early Parkinson's. They are low potency drugs, but they are very, very well tolerated medications. Practically no side effects. I haven't seen any side effects with these medications. Common known side effects are nausea. They cause a little bit of insomnia, so they should always be given during daytime. Minimal hallucinations and minimal headache. The only thing that should be careful with these three drugs is you should avoid them with SSRIs and tricyclic antidepressants, because both these drugs are also metabolized by the MAO enzyme. So if you use it with these drugs, the levels of these drugs will increase. So you should avoid using selegiline, rasagiline with these drugs. So if you have a patient who has very minimal symptoms and where you're not sure it is Parkinson's, you don't know how aggressively to treat, it is very safe to start any of these medications. Rasagiline is the commonest used. You can start with 0.5 milligram OD and go up to 1 milligram OD. So for routine clinical practice, it is a very, very safe medication to start. You can start this medicine and send the patient for a reference to a neurologist. Then you have amantadine. Again, this is a drug which is used for very early Parkinson's. It is again a low potency anti-Parkinsonian drug. It is again very well tolerated. You should use it in young patients. Patient early Parkinson's, you can use safely amantadine. The only drawback with amantadine is that they start developing tolerance to this medicine. So the effect does not last for too long. The effect might go off in 3 to 4 years. So if you've kept the patient on amantadine for 3 years and the patient says, now I'm getting worse, immediately you need to switch to the next level treatment. Dose of amantadine is 100 milligram twice a day or thrice a day. Renal failure patients do not use amantadine. The side effects of amantadine that you should know is ankle edema. So if you started amantadine for a patient and they come to you with edema feet, it might be amantadine induced. The other common side effects are confusion, hallucinations, and nightmares. So if you have a patient of Parkinson's whom you have started amantadine and they come to you with confusion, hallucinations, and nightmares, you should immediately stop amantadine. Now, important point in using amantadine is you should use it very early in the morning, somewhere around 8 o'clock. And the last dose should not be beyond 4 o'clock in the evening. So BD means 8 a.m. and 4 p.m. TID means 8 a.m., 1 p.m. and 4 p.m. latest by 5 p.m. because they tend to cause a lot of hallucinations during the night, one, and they reduce sleep. So they can cause insomnia. So do not use amantadine beyond 5 o'clock. Then come to tremor dominant Parkinson's, where you have tremor as the predominant symptom. They are not significantly bradykinetic or they don't have too many gait disturbances. Then we all know that what we use, all of us use Pacitine or trihexyphenidyl. So these are basically anticholinergic drugs. Now, this I want to stress upon is because this is one drug which lot of practitioners start when patient comes to us with tremors. Now, these anticholinergics are not the best drugs. Why they are not the best drugs? First is they've got plenty of side effects. The commonest side effect is cognitive impairment. They cause urinary retention, they cause constipation, and they cause profound hallucinations and psychosis. So if you have a patient on Pacitine for 3-4 months and they come to you saying that I have started losing memory, it's because of Pacitine. You need to stop the Pacitine immediately. Never use Pacitine in people who have BPH, that is prostate. Avoid Pacitine in patients who are elderly or those patients who are having subnormal mentation, those who are mentally retarded or subnormal mentation, or those who are demented, and those who are having chronic constipation, because Pacitine worsens constipation. avoid Pacetane in patients who have a history of psychiatric illness because it can really worsen the hallucinations. And by rule, do not use Pacetane in patients who are more than 65 years of age. Avoid as much as possible. So that's what I meant. And again, if the patient has glaucoma, do not use Pacetane in patients with glaucoma. Now, this is about mild disease. So mild disease, you have racegelin, salicylin, and safinamide and amantadine as treatment options. When now you have patients with mild to moderate disease and the disease is affecting their activities of daily living, then you need to go to these drugs. That is dopamine agonists or dopamine precursors, which is levodopa. Now, these are the dopamine agonists that are available: ropinirole, ropinirole XR, that is Ropark XL, Pramipex, Pramipex XR, and apomorphine. This is the dose. You can note down the dose. I'm not getting into the dose details. What I'm trying to focus here is the side effects of these drugs. So they are commonly causing nausea, vomiting, and sleepiness. They cause a lot of orthostatic hypotension and confusion and hallucinations. If you have started the patient on Ropark or Pramipex and they come to you with confusion and hallucinations, or if any neurologist has started the patient on confusion and hallucination, they come to you with these symptoms, take off the drug, that is your Ropark or Pramipex. Immediately take it off. So that is a very important point with Ropark and Pramipex. Then they cause a lot of edema. So if you have referred a patient to a neurologist, they have started them on Ropark or Pramipexole and they come to you with edema fit. So you should be aware that Ropark and Pramipex can cause edema fit. So that is a very important point here, that these drugs cause a lot of peripheral edema. Then you have levodopa. Levodopa is your syndopa. Now I'm concentrating more on this. This is the best drug that is available to treat Parkinson's. That's the best drug to treat Parkinson's. Why it is the best drug? It has got excellent control over the motor symptoms. It has got excellent control over bradykinesia, excellent control over tremors, and very good symptomatic relief in terms of gait. Second is you can use it at any age, any severity of symptoms. The only problem with levodopa, early use of levodopa, is that after 6 to 7 years, the levodopa effect starts wearing off. So they don't, become very responsive to levodopa. So the basic principle of using levodopa is you start with a very low dose and gradually build up the dose. Avoid levodopa in younger patients because they tend to develop a lot of motor complications after 6 to 7 years. So you should always preserve levodopa for later stages. So if you have a young 45-year-old with minimal Parkinson's, don't start them on syndopa immediately. You have a lot of other options that we saw earlier. You start them with any of those drugs and preserve levodopa for later on. So that is very important. But if the young patient has moderate or severe symptoms, do not deprive them of levodopa. You should always give them levodopa. So levodopa is available in various preparations. One is levodopa that is called as Syndopa 110. It is available in Syndopa Plus formulation, and it is also available in Syndopa CR formulation. So whenever you start Syndopa, 2-3 things, clinical points I'll tell you. First is always start with half tablet 3 times a day. The timing should be 9 o'clock, 1 o'clock, 5 o'clock. Don't give Syndopa beyond 5 o'clock. They can cause a lot of hallucinations. Start with half 3 times a day for 5 to 7 days. Then make it full tablet 3 times a day. Second point that you should always tell the patient about 3 side effects of Syndopa. First is orthostatic dizziness. So you should always tell them कि जब भी खड़े होंगे तो थोड़ा सा dizzy लगता है. That goes off with time. Second, it causes nausea early on into the treatment. So you should always advise them that it can cause nausea. If there is too much of nausea, you can use domperidone. Otherwise, avoid domperidone as much as possible. The third side effect that you should tell the relative is about hallucinations. So if you have started Syndopa to a patient, tell the relative that if the patient starts hallucinating, please stop the Syndopa and come and inform me. So that's the second thing that you should tell the patient. Third important clinical point about Syndopa is initially you give Syndopa after food for the first 5 to 7 days. Once you know that the patient is not having any nausea, vomiting with Syndopa, then you try to shift them to 30 minutes before meals. Syndopa best acts when it is taken on empty stomach. So these are a few clinical pointers about how do you use Syndopa. So that's what I mentioned here. So I'll go beyond this. What are the side effects of Syndopa? nausea,
નહીં લે હું જઉં છું ઉપર
dizziness, they
હા
cause
તું નહીં લે પણ તાર 10 વાગે જવાનું છે ને
hallucinations, and they can also cause B12 deficiency, and they can give rise to an increase in homocysteine levels. So these are not very known side effects, but they are side effects of Sigdopa. So commonest side effects are nausea, sleepiness, dizziness, and confusions, hallucinations, delusions, and psychosis, and orthostatic hypotension. So if you have any of these confusion, hallucination, delusions, you should always tell the relative to stop the drug and come back and inform you. So this is again the same thing. I'm not going into this. If you have old patients who are having cognitive issues, the drug of choice is levodopa. The other drugs like dopamine agonist, amantadine, MAO inhibitors, you should avoid them because they can cause neuropsychiatric side effects. But those who are old patients but they are cognitively absolutely normal, you can use dopamine agonists in them with levodopa. Now you come to advanced Parkinson's. Advanced Parkinson's, I'll just give you a brief idea about DBS. So that's one of the surgical treatment options, that is deep brain stimulation. Deep brain stimulation was introduced by Benabid and Pollack in 1987. What is the basic principle of deep brain stimulation is there is basically a chest implanted stimulator, and this has got electrodes which are implanted into the basal ganglia structures. So they give high frequency electrical stimulation to these basal ganglia structures, which improves the dopamine release and it helps in Parkinson's. Now, who are the candidates for deep brain stimulation? First important thing is not all patients can be taken for deep brain stimulation. Those patients who have done very well with levodopa, only those patients should be referred for deep brain stimulation. Second, those patients who are not demented, patients should be cognitively intact before going for deep brain stimulation. Deep brain stimulation can be used in those patients who have responded to levodopa but who have levodopa induced side effects like wearing off, dose failures, fluctuations, sudden offs, dyskinesias. There you should advise them deep brain stimulation. Those who have responded to levodopa but still Parkinson is affecting their quality of life, there you should use deep brain stimulation. And last indication is you have tried all medications in the patient is doing very well except that his tremors are just not going, that is refractory tremors, you can use deep brain stimulation. So these are a few indications. Most important is that the patient should have responded to levodopa. If the patient is not responding to levodopa, there is no point doing deep brain stimulation. So that's about Parkinson's. A lot of other things. It's a very detailed topic, but I'll stop here. Any questions you can ask me?
Yes, Dr. Dinesh, there are a few questions in the chat box. One question from Dr. Utpal Shet. How will it be differentiated limb muscular weakness and stiffness that also has reduced gait speed, difficult to initiate movement, stiffness, pain may or may not be there?
Correct. So if you examine a Parkinsonian patient and if you examine a patient with muscle weakness, if you ask the patient to lie down on the bed and you actually do power testing, the Parkinson's patient's power will be absolutely normal. Whereas any patient with any muscle disorder or any muscular weakness, if you try to test their muscle strength, the muscle strength will be definitely less. One. Second is the main problem comes in the slowness of movements in weakness and in Parkinson's. Now that's what I had mentioned when I mentioned bradykinesia. It's not only the speed of movement, but it is also the amplitude of movement. So in any muscular weakness, the speed will be normal. It will just be the amplitude of movement that will be reduced. Whereas in Parkinson's patient, the speed will also be reduced. The amplitude will also be reduced. These are the main things in how you differentiate a muscular and a Parkinsonian weakness. Third, there should be additional signs like tremors. There should be additional signs like rigidity. Rigidity you will never find in muscular weakness. On the contrary, in patients with muscle weakness, you will have hypotonia. That is, the tone will be low. And fourth point is in Parkinsonian patients, if you check their deep tendon reflexes, they will be absolutely intact or they might be brisk. Whereas in any muscle patient, if you check their deep tendon reflexes, it would probably be absent or it will be on the low side, it will be sluggish. So that's how you differentiate a muscular weakness from actually an extrapyramidal weakness.
Okay. So there is one more question from Dr. Savita Gokhale. She is asking the antipsychotic drugs that you have mentioned in the side, so that may cause Parkinson's in future.
Right.
Will that? Yeah. Yeah. So it says, will that also occur if the medications are taken for short term, that is up to 1 to 2 years?
Yeah, see, I have seen a lot of patients, these anti-Parkinson these Parkinsonian side effects with antipsychotics, first and foremost, they are usually seen in old people. So in old people, it usually comes because they already have less dopaminergic reserve. So in these patients, it can come at any time. I have seen patients who have started antidepressants and antipsychotics, they've started getting Parkinsonian symptoms within a month, within 3 months also. So that is why whenever we start antipsychotics to any patient, periodic clinical examination is very, very important. And the psychiatrist should be clinically oriented to pick up early Parkinsonian signs. So there are no time limits or no timelines to actually develop Parkinsonism, but older patients develop earlier. Younger patients will develop maybe after 2 to 3 years of taking antipsychotics. But older patients will definitely develop earlier. So you should always be on the lookout for Parkinsonism if you have prescribed antipsychotics to your patient.
So there is a question from Dr. Vinod Birajdar. He's saying, is Lewy body present in Parkinson's disease, or it's a different disorder?
No,
Does CT scan have any role to diagnose PD?
No, CT scan does not. I'll answer the second question. CT scan has got no role in diagnosing PD, but CT scan is required to exclude mimics of Parkinson's. Like, as I mentioned, frontal lobe tumors. So if you do a CT scan, you will be able to pick up a frontal lobe tumor. Second is, if there is hydrocephalus and you do a CT scan, you will be able to pick up a hydrocephalus. So these are only to differentiate other mimics of Parkinson's, but not to diagnose Parkinson's disease. Now coming to the Lewy body is basically a pathological entity. Now Parkinson's per se has got a lot of, these are basically inclusion bodies. So what these Lewy bodies and alpha synuclein, these are all inclusion bodies. What they do is they enter our cells of the dopaminergic system, and they are toxic to these cells. And that's how they damage the cells. Now, Parkinson's is one of the inclusions in Parkinson's disease is Lewy body, but there are a lot of other inclusions also, like alpha-synuclein and a lot of other things. Lewy body is one of the inclusions, but there is a separate disease which is called as Lewy body dementia, where Lewy body inclusions are the maximum inclusions in those patients, where most of the cells are destroyed by Lewy bodies. So that is a completely different term, which is called as dementia with Lewy body. Now that is an atypical Parkinson's syndrome. In pure idiopathic Parkinson's disease, you might not have that much Lewy body when you do a biopsy. But if you have too much Lewy bodies when you do a biopsy, it probably points towards an atypical Parkinson's syndrome, which is called as dementia with Lewy body. So that's about the Lewy body in Parkinson's.
Yeah. There's a question from Dr. Kajal. She's asking how to monitor timing for drugs if it's more than 4 times.
If it is more than 4 times, you should always ask the patient what time the patient gets up first. So if you are using Syndopa, we use Syndopa even 6 times or 7 times a day. If you're using Syndopa and the patient wakes up at say 6 o'clock, so you should always tell that the first dose you take at 6 or 6:30, that is before your tea, and you can use Syndopa at intervals of 3.5 to 4 hours, because the Syndopa effect stays only for 3.5 to 4 hours. So you can use it at 6 o'clock, 9:30, 12:30, 3:30, and last dose I usually don't give beyond 6 to 6:30. You can finish off by 6 to 6:30. You can even shorten the dose time. You can make it every 2 hours, 2.5 hours also. So that doesn't matter. What matters is what time the patient gets up.
The last question is there any age restriction for deep brain stimulation?
No, there is no age restriction. It is what is important is that the patient should be cognitively intact. If the patient is cognitively intact, you can do deep brain stimulation at any age. And the second thing is that the patient should have responded to levodopa before you actually go for deep brain stimulation. There is no age limitation for deep brain stimulation. I